Brian, one of the questions that I'm often asked by a community physician is TKI and radiation, TKI after radiation, how much time in between? How do you apply that in your practice?
I mean, we use a lot of gamma knife radiotherapy at Cleveland Clinic, and so we tend to do that first and then start them on TKI, really because there's probably no urgency to start the TKI. The other practical thing is it often takes, a week or two to get drug supply, going through reimbursement and prior authorization, et cetera. So it usually works out that if during our initial staging workup we discover a brain met or more, we arrange their MRI and gamma knife while we're in parallel trying to get them access to a TKI or a clinical trial, though those patients aren't often eligible. And then the timing usually works out. I think you can overlap them. I don't think there are safety issues. We've done it in other settings where we radiate bone for pain reasons, et cetera. But in this particular setting, it usually works out to be separate.
Jan, you have some thoughts about that?
I just was going to comment that in the expanded access studies of sorafenib and sunitinib prior to their being available commercially, there were patients that had had treated brain mets treated successfully, and they did quite well. So they kind of mirrored the overall population. So we do have populations that are not the clinical trial specimen, that in fact those patients can be successfully treated.
So Danny, let's turn our attention to the 20 to 30% of patients that present with non-clear cell histologies, which we all see: papillary type 1, papillary type 2, XP translocated tumors, medullary carcinoma, undifferentiated cancer, chromophobe metastatic, although infrequent. How do you approach that group of patients?
I think we spend a lot of time thinking about the different histologies and getting pathology reviews for them. And I think they're important to distinguish just because they have different prognoses. So for example, non-clear cell populations with metastatic disease tend not to have as good a prognosis when treated with targeted therapy compared to those with clear cell disease. But the honest truth is I don't think we're good enough yet to actually know which treatment is best for which subgroup. So my practice has been to treat the non-clear cell population very similarly to how I treat the clear cell population. There are some subgroup analyses, especially with mTOR inhibitors such as temsirolimus, that specifically did look at non-clear cell carcinomas, and so we can use temsirolimus in non-clear cell carcinomas. But actually, there was recently a clinical trial that will be presented at ASCO in 2014 that looks at using sunitinib versus everolimus frontline for non-clear cell carcinomas. And actually, the progression-free survivals are actually quite inferior to historical controls for clear cell carcinomas, but 6.1 months versus 4.1 months for sunitinib versus everolimus for first line. So it suggests that maybe we can treat our non-clear cell carcinomas very similarly to clear cell. We shouldn't use everolimus first line, and we can stick with what we normally do.
And Brian, we're spending a lot more time thinking about next generation sequencing in cancer. Does it give us some insight into how to select targets that are actionable mutations? Any role for integrating next-gen sequencing into this non-clear cell histology population, or are you thinking about that at Cleveland Clinic?
I mean, we're not doing it routinely, probably mostly from a cost perspective, but it's a group of patients where the biology is poorly understood. There was an abstract here from the French group, I believe, looking at papillary type 2 and showing that even within that subgroup, there was other subgroups, really pointing out, as Danny said, how little we know about the biology of this really probably very wide spectrum of disease. So it's not at all ready for prime-time clinical practice, but I think that's a great population of patients in whom to sequence just to get smarter about the biology of the disease.